Let me tell you about one of the strangest numbers in public policy. If government engineers determine that installing a new safety barrier on a highway will save 10 lives, they can get a budget of $100 million approved. Why? Because on their official spreadsheets, the value of a statistical life in the U.S. is currently pegged at around $11.4 million. We are, on paper, willing to spend an extraordinary amount of money to stop a single, immediate, preventable death. So you'd assume, logically, that we'd be even more obsessed with investing in the thing that determines the quality of our entire lives, right? The thing that dictates whether our final decade is spent hiking and playing with grandkids or in a state of chronic illness. But here's where the logic completely falls apart. When you look at what we actually spend on preventative health, the actions that slow down aging and stop us from getting sick in the first place, it's less than 3% of our total healthcare budget. It's a rounding error. We'll spend a fortune to keep your car from flying off a cliff, but we invest almost nothing in maintaining the engine to ensure it doesn't break down 10 miles from your final destination. This massive illogical disconnect between how much we say a life is worth and how little we invest in living it well is the single biggest story of our time, and almost no one is talking about it. That, for you, is the paradox we are diving into today. Our mission is to investigate the economic policy frameworks, the public health investment strategies, and the societal shifts required for developed nations to transition from simply managing an aging population, managing the breakdown, to actively fostering a productive longevity society. We need to figure out how to bridge this staggering gap, why we assign an $11.4 million value to preventing an acute crisis, but treat long-term health maintenance as, well, a negligible cost.
It's fascinating, isn't it? Because that $11.4 million figure, it isn't just plucked out of thin air. It's a quantified economic measure, really, of risk reduction. Society tends to panic, and pays these premium prices to eliminate immediate risk.
Right. The sudden scary event.
Exactly. But that same instinct, it completely fails us when we're addressing the slow burn crisis, like chronic disease, which, let's face it, dictates the quality of our later years far more than, say, a highway barrier.
So connecting this to the bigger picture, what we really need is a complete conceptual overhaul.
Absolutely. We've got to move away from just reactive crisis management. We need strategic, long-term health and economic development that really spans the entire working life continuum. It's a fundamental shift in thinking.
Okay, let's unpack that conceptual leap you mentioned. Because the language we use, it really matters here, doesn't it? Historically, whenever we talk about, more older people in society,
we default straight to the aging society mindset.
Yeah. And that perspective, it's anchored in that old three-stage model of life. You learn, you work, you retire. And that really limits our view.
It does more than limit, I think. It fundamentally reduces the conversation. That traditional model, it sees extended life primarily as a consumption challenge.
And a fiscal burden, right?
Yeah.
Pensions, healthcare costs, long-term care.
Precisely. It just pigeonholes seniors based on their demographic status. It only focuses on those end-of-life needs. It's a very narrow lens.
So the longevity economy approach, that's the corrective lens we need. It flips the script.
It flips the script entirely. It acknowledges the major shift isn't just that people are getting older, but that there's this significant extended period of healthy potential life now available. It's a resource, not just a cost. And this transition, it compels us to exploit the immense flexibility and, frankly, the capabilities that exist across all age groups, not just the young ones.
So we need to move beyond just counting mortality stats.
Way beyond. We need to look at the potential for continued economic contribution, social contribution. It's really about ensuring those extra years are healthier, more productive, and, well, fulfilling.
So we're talking about building a longevity society, and that requires more than just better health insurance, I take it.
Oh, much more. It requires societal restructuring from the ground up, really, recognizing that aging isn't something that just happens at 65. It starts at birth.
Right.
So we need to structure social lives, working lives, from the very beginning to reflect this new reality. I mean, think about it. A child born today might live to 100, maybe even beyond.
Wow.
We can't just bolt 30 extra years onto the end of that old three-stage model. It won't work. We have to foster active, healthy aging right from the early stages. We need policies that positively impact how we grow old.
And change the narrative too, right? Get rid of the negativity around aging.
Exactly. Emphasize novelty, purpose, value. Promote this idea of a multi-stage life where learning, working, free time, it's all more fluid, managed across the whole lifespan.
That dynamic, lifelong investment idea. It reminds me of Andrew J. Scott's concept of the Evergreen Agenda. I love that phrase.
That's a great phrase.
It implies, universal and continual relevance. It's like a policy for society, but also an individual state of being prepared for longevity.
It really is the ultimate preventative strategy. And it's about sustainable, proactive investment throughout the entire course of life, across 4 crucial areas, and they're all interwoven.
Okay, what are they?
You need to invest continually, dynamically in your finances, obviously, but also your health, your skills, and your relationships.
All 4. You can't neglect one.
No, because they reinforce each other. Neglect any one of those earlier in life, and you seriously compromise your ability to thrive in those later decades. Like, say you don't keep your professional skills updated in your 40s.
Then your ability to keep working productively in your 60s is shot, and so is your financial well-being.
Exactly. It's all connected.
Okay, the individual investment part seems clear, though maybe hard to do consistently. But what about the system? An individual can't fix a rigid job market or, bad city planning on their own?
No, they can't. That's where institutional policy has to step in. Governments absolutely must enact measures that directly support this evergreen mindset.
Like what?
Well, encouraging flexible retirement schemes, for starters, letting people transition out of full-time work gradually, maybe go part-time instead of a sudden stop.
Makes sense.
We definitely need widespread workplace adaptations, things that acknowledge the value of older workers' experience and, importantly, prevent age-related injuries. And crucially, much more investment, public and private, in lifelong learning and reskilling programs.
Lifelong learning feels key. Skills get outdated fast these days. If you're going to work for 50 or 60 years.
You absolutely need policy to help you upskill in your 40s and 50s. It's not optional anymore.
And city planning.
Yes, we have to evolve urban planning too. We need genuinely age-friendly cities. Accessible, inclusive, designed to foster intergenerational interaction and community.
Yeah, because if the sidewalks or the buses only work for people who are perfectly fit,
you create a massive barrier for a huge chunk of the population. It's a social barrier and an economic one.
So if this Evergreen Agenda is such a good map for investing across life, why aren't we following it? Often it feels like the reason isn't purely economic. It feels cultural.
It often is.
And the biggest cultural hurdle in longevity, I think, is hands down ageism.
Ageism is a huge barrier, a major economic and social barrier preventing this productive longevity society from really taking hold. And it is incredibly pervasive.
The stats are shocking.
They really are. The World Health Organization, the UN, they estimate that every second person globally holds ageist attitudes.
Wow. Half the planet.
Yeah. This prejudice, based just on how old someone is, it shows up everywhere. Job interviews, casual comments, social media, even in institutional policies.
And the consequences aren't trivial. We're not just talking about hurt feelings.
No, not at all. We're talking about poorer physical health, poorer mental health, increased social isolation, greater financial insecurity, and tragically, even premature death.
Can we quantify that?
We can. The mental health toll alone, an estimated 6.3 million cases of depression globally, are thought to be directly attributable to ageism.
That's staggering.
But maybe the most revealing number, linking right back to that paradox we started with, is the economic cost. In the U.S., a 2020 study found that ageism, specifically negative age stereotypes people hold and negative self-perceptions about their own aging, led to excess annual costs of U.S. $63 billion, just for the 8 most expensive health conditions affecting Americans over 60.
Wait. $63 billion in excess costs. So not the total cost, but extra costs caused by ageism.
That's right. It means $1 in every 7 spent on those specific conditions for older Americans is essentially wasted, burned, due to the physiological and psychological impacts of ageism itself. That's like a massive subsidy we're paying just to keep holding on to prejudice. It's insane.
It is. And the research, it actually details the pathways of harm. It shows how deep this damage goes. There are basically 3 main routes.
Okay.
First, psychologically. Negative age stereotypes increase chronic stress. We know stress undermines overall physiological stability.
Makes sense.
Second, behaviorally. Negative self-perceptions about aging often lead to worse health habits. People might think, oh, I'm old, exercise won't help me anyway, or they might not take their medications properly.
It becomes a self-fulfilling prophecy. If society tells you you're going to decline inevitably after 60, why bother trying?
Precisely. And the third path is physiological. This one is really striking. Studies have shown that just holding negative age stereotypes predicts actual detrimental changes in the brain decades later.
What kind of changes? Things like reduced hippocampal size, accumulation of the plaques and tangles associated with cognitive decline, like Alzheimer's. So the stereotypes you internalize, maybe in your 30s or 40s, can literally show up as biological damage in your 70s.
That is deeply unsettling. We're basically investing billions in a system, in a culture that actively makes people sick and costs us more billions in healthcare down the line.
That's the reality of it.
So how do we fight something so ingrained, so cultural?
It has to be multi-pronged, no single solution. We need specific policies, laws that target ageism in workplaces, in healthcare settings. That's crucial.
Okay, laws and policies.
Then widespread educational activities, things designed to build empathy, dispel these pervasive myths, and really show the diversity of how people age. It's not monolithic.
And getting people together.
Absolutely. Prioritizing intergenerational activities, things that force people of different ages to actually work together, connect, understand each other. That helps break down the root prejudice. Building this kind of movement to fundamentally change how we think, feel, and act towards aging. It's critical if we want to make things like the UN Decade of Healthy Aging actually succeed.
Okay, let's circle back now to that money paradox we started with. The $11.4 million value for crisis prevention versus less than 3% of the healthcare budget for actual preventative health. This true price of health seems totally skewed towards crisis management. What happens if we actually do invest early?
Well, the evidence is pretty clear. Prioritizing long-term investment in human capital, especially health and education early on, in childhood, it isn't just socially good, it's fiscally essential.
How so?
Look at the return on investment, the ROI of early intervention. There are estimates, for example, that Medicaid expansions for children, they can generate up to $2 in discounted future tax revenue for every single $1 spent on expanding that program.
Whoa, double your money back to the government coffers. That's phenomenal ROI. But break that down for us. How does spending $1 on a kid's health care today turn into $2 of tax revenue years, even decades later?
It's actually pretty straightforward. Early health investment removes barriers. Barriers to learning, barriers to development. Healthier kids tend to be more consistent students, right?
Fewer sick days, better focus.
Exactly. They finish more years of education, and then they go on to earn higher lifetime incomes because they're physically and mentally capable of taking on higher skilled jobs.
And those higher lifetime earnings mean?
They translate directly into greater income tax revenue for the government over a 40 or 50-year career. It's an incredibly powerful economic engine. It really proves that preventative care isn't just a social expenditure, it's an asset investment.
So if we're living longer, the real policy focus shouldn't just be about extending lifespan, should it? It needs to be about health span, the time we actually spend in good health.
Precisely. That's the goal. What experts call compressed morbidity.
Compressed morbidity. Okay, explain that.
Think of it like maximizing your health runway. We're not just trying to add, say, 5 extra years to your life if those 5 years are spent in severe decline. The goal is ensuring the last time you're really sick or severely disabled is maybe just the final 6 months of life, not the last 6 years.
Squeezing the bad stuff into a shorter period at the very end.
Exactly. And this compression, it's strongly linked to socioeconomic status, access to quality care, and maintaining healthy habits throughout life. For this whole longevity society idea to work, policies have to enable this compression. We need workers to be able to productively extend their working life through what we can call a working life continuum approach.
Okay, to get that health span goal, we probably need to reform the healthcare system itself. Move away from just paying for volume for doing more stuff.
Yes.
Which brings us to value-based healthcare, or VBHC. The idea is to prioritize patient outcomes, like extending healthy life expectancy over just the sheer volume of services delivered.
VBHC is a really critical theoretical model, though I have to say, implementation is lagging way behind the theory.
Why is that?
Well, first, VBHC tries to answer a simple but profound question. How can we spend our healthcare dollars where they actually produce the best health results for patients? It's a field that's, interestingly, overwhelmingly dominated by U.S. research. Something like 65% of the scoping studies cited are U.S.-based.
Which is ironic, right? Given the U.S. system struggles.
It is ironic. It highlights the sheer desperation within the U.S. system to shift away from that traditional, often wasteful fee-for-service model.
But if the U.S. is doing all this research, why is actually implementing VBHC so hard on the ground? It seems like everyone agrees it's a good idea, but nobody can quite make it work at scale.
Yeah, the barriers are pretty significant, and often they're operational, not theoretical. First, you get resistance from healthcare professionals from institutions. Often it stems from a lack of real leadership buy-in at, say, the hospital level, or it's just the sheer difficulty of integrating these new VBHC metrics into the existing quality improvement systems, the existing reimbursement structures. It's a massive shift in culture and accountability.
Okay, resistance from within. What else? You mentioned operational complexity.
That's the second and maybe even bigger hurdle. The operational challenges linked to the complex costing models needed for VBHC. The flagship approach people talk about is often time-driven activity-based costing, or TDABC.
TDABC. Sounds complicated.
It is. This model demands really precise, highly functional IT systems and a super detailed understanding of every single step in a patient's care pathway.
Break that down. Why is TDABC so difficult compared to how hospitals bill now?
It's the granularity. Okay, so in a traditional fee-for-service world, the hospital knows the cost of the surgery, the cost of the room per day, maybe the cost of major drugs.
Right, big chunks.
Yeah. TDABC, however, requires you to know exactly how much time a specific nurse earning a specific salary spent with patient A versus patient B versus patient C, and what specific equipment was used during that exact minute for patient A.
Wow.
It's like trying to perfectly itemize every single minute, every resource on a complex assembly line. Many traditional healthcare settings, often built on older IT systems, they just struggle to track that level of detail accurately. And without that accurate costing,
the value-based payment models fall apart. You can't pay for value if you don't know the true cost of delivering it.
Exactly.
So it sounds like we're kind of stuck between an old, inefficient billing system and a new, potentially better one that's incredibly demanding technologically. Let's pivot now to the mortality trends themselves, because they really show where this lack of prevention and this crisis spending is hitting us the hardest. You mentioned U.S. life expectancy had actually stalled before COVID hit.
That's right. While other advanced economies kept seeing increases, it proved the stall wasn't because we'd hit some absolute upper biological limit for humans.
So what was causing the stall in the U.S.?
It was largely driven by what we can call the external causes crisis. This was hitting young and middle-aged adults particularly hard. For Americans aged 25 to 44, the mortality setbacks were overwhelmingly driven by external causes.
Like what?
Things like vehicle accidents, gun deaths, and critically drug overdoses. Drug overdoses became the leading cause of death for that 25 to 44 age group, and the fourth leading cause for those aged 45 to 64.
And this is where that $11.4 million value of statistical life paradox just manifests so brutally, isn't it?
Yeah.
We failed to invest properly in the social fabric, the mental health support, the medical structures that might have prevented the opioid epidemic from taking hold in the first place.
And now we're paying staggering amounts in crisis management, in lost lives, lost economic potential. It's a tragedy fueled by short-sightedness.
Yeah.
The opioid epidemic, it's directly linked back to aggressive pharmaceutical marketing, competition among prescribers. Things that led to much looser prescription practices for highly addictive legal opioids starting way back in the mid-90s.
And then, when policymakers finally tried to tighten up the legal prescriptions,
the demand from people already suffering from addiction was still there. It was huge. And that fueled this devastating shift towards highly dangerous illegal substitutes, primarily fentanyl, which just sent fatal overdose rates through the roof exponentially.
And the response, true to form, is this massive spending surge after the crisis is incredibly acute. We're seeing, what, $450 million in new funding announced to tackle the overdose crisis?
Yeah.
The FDA approving over-the-counter naloxone nasal spray?
Which is a crucial intervention tool, absolutely. But it is that $11.4 million VSL instinct kicking in again. We panic, and we pay big money when the problem is acute, visible, undeniable.
Meanwhile, for older Americans, the main fight is still against chronic disease, right? That still accounts for most deaths after age 45.
It does, the vast majority. But there is some good news there. Progress has been made. For instance, deaths from heart disease have been declining, largely due to reduced smoking rates over decades and genuinely better treatment protocols. But the fight is continuous. It requires targeted, persistent initiatives.
So what are we seeing now, specifically on the chronic disease policy front? Any major moves?
We are seeing some significant targeted federal efforts, yeah. You've got the ongoing Cancer Moonshot initiative that's focused on expanding access to screening, trying to expedite patents for new cancer treatment innovations.
Okay.
But a really major recent step, I think, addresses a historic fundamental flaw in medical research. It's the first ever White House initiative on women's health research.
Why is that initiative so critical for longevity and chronic disease specifically?
Because for decades, honestly, medical research was often based almost exclusively on male physiology,
Yeah.
male lab rats, male human subjects. This created profound research gaps in understanding women's health.
And that has real-world consequences.
Huge consequences. For example, we now know women and men often experience very different symptoms during a heart attack. Women might present with nausea or jaw pain, maybe extreme fatigue. Not always the classic clutching the chest symptom we see in movies, which is more typical for men.
So traditional diagnostic tools, treatment paths geared mostly towards men,
Can lead to dangerous delays or misdiagnoses for women. Addressing this historic underfunding, this research bias, is a really key preventative intervention for improving midlife and later life chronic conditions for, half the population.
Yeah. All these trends, mortality, longevity, health span, they feed into this new demographic reality that policymakers absolutely have to grapple with. The classic population pyramid, lots of young people at the bottom, few old people at the top.
Yeah, that's changing fast.
It's giving way to something that looks more like a pillar or maybe a barrel. Demographers call it demographic rectangularization.
That's the term. And it's the direct result of two really powerful simultaneous trends: people living much longer and dramatically decreased fertility rates.
The numbers are stark.
Unmistakable. The population aged 65 and over in the U.S. was about 12% back in 2000. It's projected to hit 21% by 2040. And globally, something like 2/3 of the world's population now lives in a country with below replacement fertility.
And specifically in the U.S., the total fertility rate, the TFR, is falling to, 1.67?
Yeah, around there. Significantly below the 2.1 level that's needed just to keep the population stable without immigration.
And this isn't just some random fluctuation or political talking point. It seems deeply rooted in economics, right?
Oh, absolutely. Research consistently shows that the decision to have children, it's essentially a calculation people make, consciously or unconsciously. You're balancing the immense satisfaction, the emotional value children bring against the very substantial monetary costs, and maybe even more importantly, the time opportunity costs of parenting.
Especially for women.
Especially for women, historically. With rising real incomes and really dramatically transformed labor market expectations and opportunities for women, particularly increased college education, professional careers, what economists call the substitution effect, has really taken over.
Meaning
Women, and couples more generally, choose to substitute the time and money they would have spent raising, say, a third or fourth child into things like career advancement, lifestyle choices, other forms of fulfillment. And that pushes desired family sizes downward pretty much globally.
Now, this big demographic shift, it immediately creates fiscal anxiety. You hear about the old age dependency ratio.
Right, the number of people 65 and over for every 100 working age people.
And that ratio is projected to increase sharply by something like 30% between now and 2050.
That's the projection, and it does raise legitimate concerns about how we fund social safety nets, things like Medicare, Social Security, when you potentially have fewer workers supporting a growing number of retirees.
It sounds potentially scary.
The concern is real, mathematically. But it's really crucial to acknowledge the powerful economic counterbalance that's also at play.
Which is?
Productivity growth. Analysts generally expect modest but steady labor productivity growth, maybe projected around 1.7 to 1.8% annually in the coming decades. And that rate is expected to comfortably outpace the annual growth of that dependency ratio, which is only projected at about 0.8% per year.
Okay. So even though the dependency ratio is rising, each worker is expected to produce significantly more value.
Exactly. So while the fiscal challenge is undeniable, we shouldn't ignore it, these productivity gains act as an extremely important countervailing force. They mitigate those worst-case fiscal disaster scenarios you sometimes hear about in the media.
That makes the shift towards longer, healthier working lives not just a nice idea, but maybe an economic necessity.
It really is becoming one, and the data shows it's already happening. By 2022, nearly 32%, almost a third of Americans aged 65 to 74, were expected to still be in the workforce. That's up significantly from about 20% back in 2002.
And why are people working longer? Is it choice or necessity?
It's really a mix. There are dual motivations. On one hand, you definitely have people who genuinely prefer to work longer. They're healthy, they enjoy the intellectual challenge, they get a sense of purpose, satisfaction from their careers.
Sure.
But on the other hand, let's be honest, many people must work longer Because of inadequate retirement savings, the big shift away from traditional defined benefit pensions towards things like 401ks, and of course those rising dependency ratios we just discussed, putting pressure on public systems.
And we really have to challenge that old, persistent stereotype that older workers are somehow inherently less productive.
We absolutely do. The empirical evidence is just not there to support it as a general rule. Generalized age-based productivity decline is largely a myth. There's very little proof that older workers are intrinsically less productive across the board.
But there is an interesting economic effect when they leave.
Yes, a fascinating and complex one. When knowledgeable, experienced older workers do retire, the overall productivity of the remaining workforce across all age groups can actually suffer significantly.
Why? Loss of knowledge.
Exactly. Loss of institutional knowledge, loss of mentorship, disruption of team dynamics. It can result in a measurable reduction in the overall GDP growth rate.
So retaining those experienced workers, ensuring their health and capacity is maintained, that's essential for everyone's productivity.
It really is. Which brings us to the work done by the National Institute for Occupational Safety and Health, NIOSH. They developed a conceptual framework specifically for productive aging at work. And this framework is vital for adapting the workplace to these longer working lives.
Okay, tell us about that framework. You said 4 elements.
Yes, 4 key elements. It's basically the blueprint for creating a longevity-ready workplace. First is adopting a lifespan perspective.
Meaning?
Recognizing that aging isn't just about old age. It reflects all the cumulative changes, biological, cognitive, sociocultural, that happen over the entire course of life.
So aging is a concern for all workers, not just those near retirement.
Exactly. Because the threats or opportunities experienced in earlier midlife, think about chronic stress, poor safety conditions early on, or maybe lack of skills training in your 30s. They directly affect your capacity and opportunity later in life.
That's a really important distinction. It's cumulative. A 40-year-old construction worker with years of physical wear and tear might need more intervention than a healthy 70-year-old knowledge worker.
Precisely. It's about the individual's trajectory, not just their age. The second element is a comprehensive, integrated approach to occupational safety and health. The best example of this is the total worker health, or TWH, concept.
Total worker health, what does that involve?
TWH integrates protection from traditional workplace hazards, controlling chemical exposures, ergonomic risks, things like that, with the active promotion of injury and illness prevention efforts to advance overall well-being.
So it goes beyond just safety gear.
Oh, yeah. This is where you start addressing things like obesity, cardiovascular disease risks, mental health support, stress management for all ages, and crucially recognizing that well-being on the job and off the job are interconnected. Work affects home life affects work.
So when employers run wellness programs, it's not just a nice little perk anymore. It's actually about managing a core business asset, the health and capacity of their employees to maintain productivity throughout a potentially longer working life.
That's exactly the right way to think about it, which leads directly to the third element, emphasis on positive outcomes for both workers and organizations.
Mutual benefits.
Yes, prioritizing outcomes that benefit both sides. For the worker, it's about safety, health, feeling respected, having opportunities across their whole life course. For the organization, it's about decreased costs, lower healthcare spending, reduced turnover, less absenteeism and improved productivity, better retention of experience, easier knowledge transfer.
The key mindset shift here for employers seems to be viewing employee health not just as a cost to be minimized,
but as an asset to be managed, invested in, and nurtured, just like any other critical business asset.
And the fourth element, it tackles the generational mix.
Right. The fourth is creating a supportive culture for multi-generational issues, because today's workplaces, realistically, can have up to 5 distinct generations working side by side. You've got traditionals, baby boomers, Gen X, millennials, Gen Z.
And they all have different values, different work styles, different expectations.
Often, yes. For instance, the demand for better work-life balance is typically much stronger and less negotiable for millennials and Gen Z compared to, say, boomers. So this element demands that policies avoid using inaccurate, oversimplified stereotypes based just on broad age categories.
Because the differences within a generation can be huge, too.
Exactly. The differences within age cohorts, like, say, between millennials from different socioeconomic backgrounds or different industries, can be just as significant, if not more so, than the average differences between generations. We need nuance.
This whole NIOSH framework, it really points towards the disruption of that old 3-stage life model. Learn, work, retire, And the emergence of what people are calling the multi-stage life.
Yes, where learning, working, periods of leisure, or retraining, they become much more fluid and interwoven throughout life.
And this transition seems particularly acute, maybe even challenging, during that period sometimes called Q3, roughly ages 50 to 75.
Q3 is definitely no longer just the slow wind down towards retirement. It's a distinct, potentially long and active stage of life that requires preparation. But for many high-skilled professionals, think lawyers, people in finance, doctors, this transition presents a really profound challenge.
Why?
Well, often they're just so overwhelmed by their immediate, very demanding workload in their 50s and early 60s. They become highly reluctant to actually plan for Q3. They might see planning a staged exit or thinking about a career pivot as just another hurdle to deal with, or maybe even subconsciously as a sign of weakness.
And their identity is so deeply wrapped up in their job title, right? Their status, their expertise, maybe their billable hours.
Completely. We all know that type, maybe the senior partner or the renowned surgeon, who retires abruptly and then seems completely lost within 6 months or a year. Tying their sense of self-worth so tightly to that professional role can lead to a fundamental loss of identity when they stop working. And that often triggers declines in physical and mental health.
So Q3 becomes this kind of personal reckoning.
It really does. It forces people, or should force them, to figure out what their life is really for beyond that specific professional identity that might have defined them for decades.
Are organizations starting to help with this? Are there solutions emerging, especially in those high-skill fields?
Thankfully, yes. Organizations are starting to experiment. We're seeing some professional service firms design more structured, staged exits or create emeritus roles where senior partners can gradually transition their work, their client relationships, their equity over several years, rather than a cliff edge.
That sounds sensible.
And you see pioneering programs like Unilever's UWork program that's designed to retain senior staff on flexible, project-based contracts. They get guaranteed minimum benefits, but they work on specific, often short-term projects. It keeps their valuable brain power and their networks active within the company, but without the demands of a full-time role.
So whether it's a staged exit or maybe a major career pivot into something new or this kind of flexible project work, what's the common thread for making Q3 successful and healthy?
Underneath it all, the really crucial thread seems to be purpose. Research consistently shows a strong correlation between better physical health, better mental health, and having a continued sense of purpose in life, regardless of traditional retirement status.
So the planning process for Q3, it's not just financial planning, it's purpose planning.
Exactly. It becomes maybe the ultimate preventative health investment. It forces the individual to really think about, okay, what do I want to contribute next? What matters to me beyond the old job title? Ensuring those extended years are actually used for fulfillment, for contribution, for connection.
And that emotional shift towards purpose.
It probably sustains health and productivity far more effectively and certainly more cheaply than any expensive last-minute medical procedure when things start to break down. It's really the final crucial piece in building a genuine longevity society. #outro.
Okay, let's try to synthesize all this. Let's return one last time to that central, frankly baffling paradox we started with. This massive public policy oversight where we value a statistical life at $11.4 million for immediate crisis prevention.
Yeah.
But we refuse systemically to apply anything like that valuation to the long-term slow burn threats to a healthy life. The things that actually determine quality of life for decades.
And what we've seen today is that this failure to invest in prevention, that tiny sub 3% spending on keeping people healthy in the first place, it directly feeds the escalating costs of chronic illness later on.
And it's made tragically worse by pervasive ageism.
Absolutely. We're literally paying, $63 billion in excess annual healthcare costs in the U.S., largely because of the negative stereotypes and self-perceptions about aging that we just allow to flourish in our culture.
So the shift that's required seems crystal clear. We have to transition from just passively managing an aging population, dealing with the problems as they arise,
to actively cultivating a period of productive longevity. A whole new stage of life, really.
And that requires adopting these integrated, lifespan public health strategies, like total worker health.
Supporting multi-stage working lives, flexible employment schemes that work for different ages.
And fundamentally reforming our healthcare investment towards truly preventative models, maybe value-based models like BBHC, if we can ever figure out how to implement them properly.
And when you look at the evidence, like that immense return on investment from early human capital spending, remember, Every dollar spent on a child's health potentially yielding $2 back in future tax revenue.
Yeah, that was striking.
It becomes just impossible, logically, to keep viewing preventative health as merely a cost center or some kind of social nice-to-have. It is not an expense. It is arguably the most powerful and potentially most profitable long-term economic strategy available to us.
So we have the economic validation. We have the demographic imperative. The need is clear. And we even have the frameworks, things like the Evergreen Agenda, the 9 principles for productive aging. The tools are there.
They are.
The true imperative, then, of this longevity society, it's recognizing that consistent, lifelong investment in our health, yes, but also in our skills, our finances, our relationships, and ultimately, our purpose isn't just some social obligation. It's the single most profitable economic decision a society can make to secure its future health and its future prosperity.